the concept of a silent stroke, where the smaller blood vessels of the brain have been damaged chronically over a long period of time in areas of the brain that we're not necessarily accessing regularly, is the most common form and presentation of vascular dementia.
Welcome to Let's Talk Alzheimer's, your place to go for the most up-to-date conversations with world-renowned research scientists and doctors. And now, Let's Talk Alzheimer's with your host, Nancy Keach.
Welcome to Let's Talk Alzheimer's, a podcast from BrightFocus Foundation's Alzheimer's Disease Research Program. So there's a very strong connection between heart health and brain health. We often read that Alzheimer's disease is the most common cause of dementia. But a growing number of researchers are saying that the causes are more often due to a mix of factors, including brain injury due to blocked or reduced blood flow to the brain, along with Alzheimer's pathology. So I spoke recently with Dr. Jason Hinman, a stroke and dementia expert at UCLA, and he explained the similarities and the differences between stroke, vascular dementia, and Alzheimer's disease. And he talked with us about why mixed dementia is the norm, not the exception. Here's our conversation about the connection between what happens in the heart and the brain. Welcome, Dr. Hinman.
Thank you, Nancy, and thank you to BrightFocus. I'm delighted to be here this morning.
So I'm going to start very basic, and then we'll get a lot more complex and in the weeds. But what is a stroke, and how do we know when a stroke has occurred?
Stroke generally falls into two broad categories. The vast majority, about 85% of strokes, result from a lack of blood flow to the brain. This typically occurs acutely, and depending on where it occurs in the brain, that dictates what symptoms will result from it. The second major type of stroke is what's called a hemorrhagic stroke, or involves bleeding into the brain or the space around the brain, called the subarachnoid space. And these can be significantly disabling strokes. They fortunately make up a minority, but they also, depending on where that bleeding occurs, dictates what symptoms are predominant. Generally, in the US, we use an acronym for stroke awareness. I'll talk about it briefly. So we use the term be fast. So the first symptom that can be a sign of acute stroke is a sudden change in balance. E stands for a sudden change in eyesight or vision. F is a facial asymmetry, one side of the face drooping. A is for arm weakness, so inability to use one's arm or difficulty using the arm. S is for speech, so acute changes in speech that occur. And the T is a warning. That's the action plan, which is it's time to get treatment right away. And so there are other symptoms of stroke that can occur, but these are some of the most common and a very useful acronym that the American Heart Association has adopted and tried to utilize around the country.
Someone actually asked about something I had never heard of called alexia. I know aphasia, which is that inability to speak, but I had not heard of alexia, which I guess is an inability to read. Is that potentially a symptom, or is that a result, or no relation?
No, it can be a symptom of stroke. It's not a particularly common symptom, although with increased mobile phone use, it has been noted as one of the things that people report when they come in, that they're having trouble using their cell phone, interpreting messages or reading the news or things of that nature. So yes, it can be a sign of acute stroke.
Diane from Texas asked, is a brain bleed the same thing as a stroke? And is a brain aneurysm that bursts the same thing as a stroke?
Yeah, it's an excellent question. We use the terminology stroke to refer to the sudden onset of neurologic symptoms. When one experiences those, we don't immediately know why that's the case. And so it's a clinical term that refers to the acute onset of neurologic deficits. A brain bleed is a form of stroke then as a result of that, both the two types that I talked about, brain bleeding that goes directly into the brain or bleeding that goes into the space around the brain called the subarachnoid space, which is often caused by a bleeding aneurysm. And so both of those are forms of stroke.
What are the differences between stroke vascular dementia, and Alzheimer's disease?
Sure. Yeah, it's a really important point, and I'm glad we're discussing it. So we just finished talking about acute stroke, which is when the first presentation of a neurologic deficit. But we understand now that a significant component of the population is at risk for damage to the smaller blood vessels. And sometimes they can become acutely blocked and cause a stroke. They usually have very limited symptoms in that scenario. They're not always disabling. They're one of the more common forms of stroke. But the smaller blood vessels are throughout the brain. And so these can also become sort of slowly occluded or damaged. And if they're not in an area of the brain that we're using regularly, let's say, the neurons that control our ability to move, walk, speak, but perhaps remember a particular piece of information, then unless we're trying to remember that piece of information, we don't necessarily know that they've been damaged. Some of the terminology that's been used recently is the concept of a silent stroke, one that it can occur in a portion of the brain that we're not accessing regularly. And therefore, we don't know that we have a problem there until these tend to accumulate over time. And this, where the smaller blood vessels of the brain have been damaged chronically over a long period of time in areas of the brain that we're not necessarily accessing regularly, is the most common form and presentation of vascular dementia. You can certainly get dementia after a large disabling stroke. And we have an active national study looking at what the risk factors of that are and how we might then tailor treatments for it. However, the more common form is this silent accumulation of vascular brain injury over time. This is different from Alzheimer's disease in its purest form, in that we don't think it necessarily involves the accumulation of brain amyloid or tau, two of the hallmark features of Alzheimer's disease. However, we understand now that most patients, when we look at brains of patients who passed away, the vast majority have components of both cerebrovascular disease, those silent strokes that I mentioned, and the brain pathologies associated with Alzheimer's disease. So it's often very difficult to separate them. And we recognize this now as kind of referring more classically to mixed dementia, that the most patients have a form of mixed dementia rather than a very specific diagnosis.
With a stroke, are there multiple symptoms like you described in Be Fast, or can there be just one of those symptoms? Or as you were just describing with vascular disease, it almost seems like there could be no symptoms too.
Strokes that require acute treatment generally have one or more of the symptoms that we describe with the Be Fast. As I indicated, those are not the only symptoms, but in the spirit of raising public awareness, we tried to think about what the most common symptoms were. So any change in acute neurologic function can be concerning for a stroke. There are very few other alternative diagnoses. And so I think that if folks are experiencing those or recognizing them in others and family members or friends, it really is appropriate to bring that family member or friend to the emergency room for evaluation. If the brain has reduced blood flow or has a brain hemorrhage, it doesn't tolerate that very long. So we really do have to take aggressive action and generally do that within the first few hours after the stroke to minimize the likelihood of long-term damage.
So if you think it may be happening, don't wait.
That's correct.
Jen from Midlothian, Texas asked, do strokes always result in vascular dementia?
No, I mean, the hidden secret is that the vast majority of patients make a strong recovery after a first stroke. They don't always return to their pre-stroke functionality, but most patients on average recover at least 65% of function. Some with smaller strokes can get back almost to normal or have very minimal symptoms that don't really affect their day-to-day life. Larger strokes can be quite disabling, and we understand from population studies in the UK that first strokes do have a risk of developing dementia over a 5-year period. It's about 40%, and it does depend on the severity of the initial stroke.
Before we leave stroke a little bit, Marlene wrote in, can you describe a watershed stroke, please?
Yeah, it's a really insightful comment. The brain has robust blood supply. There are about 400 miles of brain blood vessels that supply the brain. That's considerable. And while it does a great job, there are these areas that are deep in the brain that we refer to as watershed territories, meaning that they don't have direct blood flow themselves. They sort of share the end capillary flow from two different blood vessels where they kind of meet in the middle. And as a result, they make those areas of the brain somewhat vulnerable when the body cannot supply adequate blood flow to the brain. And this can commonly occur if one's heart stops or one has heart failure and you're unable to pump blood all the way up to those tiny capillaries in those specific regions of the brain. And it makes that area somewhat vulnerable for a stroke or lack of blood flow injury. The other thing I'd say is that this is, I mentioned two conditions where this can occur. The other thing that people should be aware of is if you have narrowings of your carotid arteries, the major arteries in the neck that bring a majority of blood supply to the brain, this can also result, if you have narrowing there, it can result in watershed strokes as a result of that. And it's something that we now can be pretty aggressive about treatment with surgery or stenting for the carotid artery.
Thank you. Now we're going to move towards the question of diagnosing and knowing which one is which when you're having symptoms. So Christopher Yu from New York asked, "What is the biomarker or other measure or observation which can distinguish between dementia and Alzheimer's dementia?"
Right now, the tools that your doctor would use to make that distinction is a structural MRI scan of your brain. There are particular sequences that we acquire on that MRI scan that can inform us about something folks may have seen in their MRI scans, often referred to as white matter hyperintensities. And these are areas of abnormality that occur generally in the frontal lobes, also in the parietal lobes, and are an indication of vascular brain injury, the type of silent stroke that we were talking about earlier. This is the best current biomarker for evaluating whether there is any component of vascular injury to one's cognitive impairment. My lab and a national consortium are also working aggressively on identifying other biomarkers. We are in the midst of finalizing a validation of 4 different novel MRI markers that can be more informative, that include things like how the brain's blood vessels react to stress, whether the MRI scan can show injury to those smaller blood vessels that are often difficult to see with routine imaging, and then some advanced measures that are precursors of those white matter hyperintensities that I was talking about. My group has also worked on a variety of blood-based biomarkers. We know that that's really transformed how we think about early detection and diagnosis of Alzheimer's disease. We're trying to apply those same principles to vascular dementia. And then the other thing that we're working on is one thing that happens when blood vessels are injured is they release some signals that say we should make new blood vessels. And so this process is called angiogenesis, or the formation of new blood vessels. And there are some markers that we're looking at as whether they're indicators of the risk for vascular dementia.
So here's a completely unfair question, but it's very exciting when you talk about, 4 potentially new or additional biomarkers and all of these and the blood tests and so on. Do you have an idea of a timeline for when some of these things might be accepted or proven to be acceptable for use?
Yeah, I think it's in the fairly soon future. I would think within 3 to 5 years, we will have convincing evidence of advanced biomarkers on the imaging side that can be utilized by your doctor and employed around the country and the world to enable early advanced detection of vascular brain injury. On the blood biomarker side, I think it could be even sooner than that. And the one of the challenges always in moving things from the research environment to sort of full scale patient access is the commercialization component. So that's often the most challenging piece, but that is in progress.
Nancy from Chicago wrote, "Is vascular dementia often misdiagnosed as Alzheimer's?" Lisa from Loxahatchee, Florida, "Why do many doctors call all forms of dementia Alzheimer's disease? Is it a lack of knowledge or something to do with insurance, possibly?" And Suzanne from Avon, Ohio, can an initial diagnosis of vascular dementia turn into Alzheimer's, or can a person have both? So there's a lot of questions along these lines. So can you respond to that? The misdiagnoses, everything being referred to as Alzheimer's. People are often given these diagnoses and not told how the doctor has arrived at them. So I think that's really an issue.
Yeah, I think it's critical. So I want to be clear, one place where we should start is being clear about the nomenclature, the naming conventions we use for these things. So dementia is an end state of not being able to utilize cognitive function in a way that it impairs the common activities of daily living, being able to get dressed, take care of oneself, manage finances, communicate, other things like that. When one reaches that stage, it's important to understand why, but we also understand that it's often difficult to reverse at that point. So, one advantage of the last few years has been that we've started to be a little more specific about the terminology we're using because we now have tools to inform the biology in living patients. When I was training just, even 12, 15 years ago, true Alzheimer's disease diagnosis was something that could only be made after one passed. And we looked at the brain for certain pathologies. And so we were guessing. The tools that we have now, such as amyloid PET scans, MRI, blood and CSF spinal fluid biomarkers, have made it possible to be more specific about the biologies that are occurring while patients are alive. And so that enables us to be more specific about what we think is the predominant contribution to a particular patient's cognitive impairment or dementia. And so I think folks should be pushing their providers to try to be more specific. For example, in the question that was provided, if I have a diagnosis of Alzheimer's disease, what is it that led my physician to make that assumption and diagnosis? And I think now we have some tools that can enable that. So whether it's a primary care or geriatrician making the diagnosis, perhaps one needs a specialty consult to be sure about that. If that particular person has had a stroke or even a stroke in the family or stroke in themselves or has, some of the common risk factors like high blood pressure and diabetes, it might warrant a specialist evaluation to say what is the main contribution and am I doing everything I can to prevent it from getting worse. And then I think finally, again, was not so important until the last few years because now we understand we have treatments. So being clear about whether one has a diagnosis of Alzheimer's disease can impact whether a patient considers the new treatments for Alzheimer's disease. Some of the main risk factors for those treatments have to do with whether you have vascular brain injury, like small brain bleeds or, uncontrolled hypertension and things like that. So we really need to be very specific about the diagnosis.
Kathy from Ithaca, New York wrote, I have been diagnosed with vascular dementia for the last 8 years. And then I was diagnosed with Alzheimer's 4 months ago when hospitalized for another stroke. Can you explain how the two overlap? I'm almost 72 this summer. She says, and now live in a great assisted living facility that is beautiful. That's nice. But it does seem, I would be confused because she had another stroke and then she gets an Alzheimer's diagnosis. So is this sort of a typical thing, or is that Alzheimer's just being used as a catch-all term potentially for dementia?
Yeah, there's always that risk that you just mentioned. I think one feature to keep in mind is that these are both diseases of aging. The smaller blood vessels of the brain don't age well. They age in an accelerated way when we have risk factors that are uncontrolled, like high blood pressure and diabetes, uncontrolled or unrecognized, I should say. And so is Alzheimer's disease. The pathologies we associate with Alzheimer's disease definitely increase as one gets older. And so I think there's always the potential for just sort of misuse of the nomenclature or the naming. However, it is possible that in this example, folks have had both, the vascular brain injury or the strokes that have caused and set up some vascular dementia, and that may then be stable for some time. And then at a later age, the pathologies such as with Alzheimer's disease start to accumulate. We're also very interested in exactly whether that fact is true that they both just can occur as we get older, or whether they synergize in an important way. And that's an open area of study. We don't have a clear answer yet.
So let me run through a couple of other things before we get to treatment. Is vascular dementia hereditary or genetic?
It can be. There are a few genetic syndromes that can lend themselves to a form of vascular dementia. The most notable and probably most recognized, even though it's still a rare, defined as a rare disease, is a condition called CADASIL. CADASIL. I won't pretend to attempt the acronym right now, and your listeners won't probably find value in that.
Fair.
But there is a foundation called Cure CADASIL that's focused on patients who have this diagnosis. It is a genetic diagnosis, generally inherited in an autosomal dominant fashion, passed from one member to the next. But it has some features that are similar to inherited forms of Alzheimer's disease, in which it only manifests in late life, generally in 50s and 60s, not as at younger ages. And so it can be difficult to diagnose. There is a national effort to understand the genetic variants here in the US that's underway and being funded by the National Institutes of Aging. That study is open for enrollment at several studies at several locations around the country, specifically for underrepresented minorities at the moment. And so that's an active area of research.
Can obstructive sleep apnea contribute to vascular dementia? Had a few questions about sleep apnea.
Yeah, I think yeah, as many know, obstructive sleep apnea is grossly underdiagnosed and even more so undertreated, in part because some of the treatments are very difficult. But we're seeing now anticipating a wave of new treatments. The new GLP-1 drugs have been FDA approved for treatment of obstructive sleep apnea. I'm told there's to be a pill for apneas coming out in the next few years. And there are a variety of medical devices beyond the treatment, beyond the classic treatment of the CPAP, which many patients have difficulty tolerating. So I think we're about to see a real revolution in treatment. Getting back to diagnosis, it's definitely underdiagnosed as a contributing factor to vascular dementia. We think that the nocturnal apneas that are associated with it tend to raise the nocturnal blood pressure. And that then directly impacts the brain, particularly at a time when we're resting, when the brain blood flow should be fairly not reduced, but sort of flat in terms of its oscillations that happen during the day. And so that can be particularly damaging to the brain. So I'm very aggressive in trying to identify it in my patients and urge them to get a sleep study and then treatment. And so I'm hopeful that we'll see a lot of new advances there that'll minimize that as a risk factor.
Michelle from Hermosa Beach, California. Are there treatment options for vascular dementia that recover function or that reroute neural pathways to inaccessible memories? And another one from Lynn from San Leandro, California. Is research being conducted to reverse vascular dementia caused by multiple strokes? So there were a lot of questions about, is there anything that sort of restores any types of function?
Yeah, it's a complex question. I'm going to break it down into two components. So, there have been some significant advances in stroke recovery over the last few years. I think it's wrong to give the message that they repair the brain in terms of, adding back neurons that are lost or things of that nature. But what they rather do is take advantage of the brain's natural plasticity, which we know is essentially inhibited after stroke. And so folks have been working to identify ways we can just augment that, whether it be with drugs or with devices. And the significant advances have been in device-based treatment. So the one I want to highlight briefly here is the use of a vagal nerve stimulator, which is a device we've used for treating patients with epilepsy for 30 or 40 years now. If you change the way the device is triggering the brain and pairing it specifically with rehabilitation, you can get remarkable improvement in motor function after stroke. Gains in arm use and range of motion and things like that. It is now FDA approved as a treatment for stroke recovery, specifically for upper limb use after strokes that affect that area and result in that disability. How it pertains to our discussion today is that we haven't really explored whether this type of thing can be used for the more complex circuits in the brain that regulate things like speech, cognition. We know that these are, sort of distributed in areas, in wide ranging areas across the brain. But the general concept of the vagal nerve stimulator and the broader concept here is that it's awakening a plasticity in the brain that is generally inhibited after stroke. So I think it's wild west in terms of what might come in the future, because as we explore this field, we can start to ask the questions of whether we can stimulate these networks that are definitely more challenging, vision, speech, cognition, but even if we can make a small dent in those, it may be impactful for patients. So that's an area that's underexplored, but I see as a wide open area.
That's fascinating. I'm so glad you brought that up because not a lot of people asked about it, which means that people don't realize that's being explored in this way. A couple of questions on, I guess it's Xarelto. Jill put in the chat, should a person stop Xarelto? Is it bad for dementia? And should a person get a Watchman? And Roger from Morristown, New Jersey wrote, is the worsening of vascular dementia more likely if taking Xarelto medication for AFib? So I don't want to talk specifically about a
Yeah.
specific brand, but
Sure, I could take a stab at that. So,
thank you.
blood thinners have an important role in stroke prevention, particularly for patients who have underlying atrial fibrillation, a heart rhythm condition that can is associated with increased risk of stroke. The decision about whether to continue them or stop them as patients may be developing cognitive impairment is a complex one. It has to be addressed with really with the whole treatment team. So often with the primary care doctor, the cardiologist, and a neurologist.
Are there, this is from Junmin on online, what types of behavioral interventions do you or other doctors recommend to help patients better recover from stroke and bring better medical treatment outcomes? Behavioral interventions, are they helpful?
We think about stroke in particular being related to or causing a specific deficit, say in motor function, inability to use the arm. And the way the brain recovers from that or augments its inhibited plasticity is through task based practice. So, just like exercising a muscle to get it stronger, one has to do repeated activities to get the circuit to make it awake, to allow it to recruit other areas of the brain to come and help that function that's been lost. And broadly, I see that principle applying to Alzheimer's disease and cognitive impairment and dementia. We often talk about mental activity and stimulation as a way to prevent dementia and to help it, keep it from getting worse in its early stages. And I think if one takes a kind of a specific task-based practice approach to that, it can be helpful. So what are the things that you're having trouble remembering in the early stages? Practice them. Work at them. Try to identify what they are and then specifically exercise them the way you might strengthen your knee after surgery or, bicep curls if you wanted to get stronger and lift the groceries. Those are the things that have to be done to make the brain respond in the right way.
John from Dallas, Texas. Is there evidence that transcranial magnetic stimulation improves vascular dementia symptoms?
At this moment, we don't have strong evidence of that, although there are a couple of studies I'm aware of that are ongoing that are beginning to look at the concept of brain stimulation in a circuit-based way to try to promote recovery or slow down the decline associated with vascular dementia.
And Eileen from Santa Monica, California. What are the predominant methods to prevent vascular strokes?
Yeah, this we were talking about this at the top of the program. I think if you were asking me to come up with one thing that folks could take away and do, it would be to measure and control your blood pressure. Worldwide, it's the leading cause of stroke. In the US, it's still, even though we have a lot of public health awareness about it, it's still under recognized and undertreated. And so being aware of what a normal blood pressure is and which I'll just say is generally for most people is under 120 over 80. And trying to get that and hit that is the most important thing folks can do to protect their brain, both from dementia as well as from stroke. We talked also about some of the metabolic health factors that folks can think about. So, diabetes, monitoring cholesterol, monitoring body weight, and then trying to adopt the proven things that can reduce the risk of those vascular risk factors, like a Mediterranean style diet, which, of course, there are good guidelines on that. There are a lot of adaptations of that. It doesn't mean eating Mediterranean food. It means the balance of the nutrients that one's taking in, staying healthy, avoiding smoking, and exercise are some of the key components.
I want to just address this quickly because a couple of questions have come in. One from Amy, one from Melissa. Amy said, I have an aunt who was recently diagnosed with vascular dementia after a stroke. And prior to this health event, she was very independent and lived on her own. We had to move her into memory care. She has a mix of confusion and depression from the radical life change and the dementia. Is there a way to help with depression in someone who is cognitively impaired? And then Melissa wrote, echoing this question, 5 years after stroke, mom now unable to stand or walk. Past 6 months, it feels like her life is over. So I want to ask you to respond to that for now, for specifically for depression, hopelessness.
Yeah, it's a very common phenomenon after stroke. It affects up to 40% of individuals. And there are, a couple reasons why folks can be depressed after a stroke. One is that they may have new disability, and that's a life change that they have to deal with and work through. But the other is that there's been a brain injury, and the balance of neurochemicals in the brain is fundamentally altered as a result of that. And so I often encourage patients to think about treatment. There is evidence that the use of antidepressants after stroke can be very effective in reducing depressive symptoms. And I would encourage folks who sort of get an immediate diagnosis of dementia after a stroke to address the mood component with their doctors because, as we know, depression can sometimes masquerade as a dementia because folks feel less engaged. They may be thinking less clearly. And in the older population, it's one of the mimics of dementia that is important to recognize because it's imminently treatable.
Thanks for listening to Let's Talk Alzheimer's. If you take one thing away from today's episode, it's this: controlling your blood pressure remains the most powerful thing that you can do to protect your brain. Mixed dementia is complicated, but the good news is that there are a lot of researchers working to better understand it and to develop better treatments. If you'd like to learn more about Alzheimer's, vascular dementia, and the heart-brain connection, visit the Alzheimer's Disease Research Program at brightfocus.org. And remember, life is so short. Tell everyone you love how much you love them. Give them a hug and hold them close to you. Have a great day. Be well.
Thanks for listening to Let's Talk Alzheimer's. If this episode helped you better understand Alzheimer's disease, please hit like and subscribe to stay informed. And if this podcast would be helpful to people you know, please share it with them. For trusted information on Alzheimer's and the latest research towards a cure, visit brightfocus.org. Get the latest information on new medications, lifestyle changes, active clinical trials, and breakthrough technologies. Thank you to our sponsors, Lilly, Biogen, Eisai, and Genentech, for making this program possible. And thank you so much for spending this time with us.
Resonate.